All right, let's do chapter 2 and start talking about some patient skills, some basic patient skills. If everyone's cool with that. Hopefully they can find these videos I'm posting on Desire to Learn. So you need to know what vital signs are. And of course, that's just somebody's vital functions, how fast they're breathing, what their pulse is, the rate and quality of respirations. You're going to learn how to take a blood pressure. I know some people have probably already done that, but how to check someone's pulse. It's important that we get their pain level. And we're basically just seeing how well the body's functioning through the vital signs. Baseline is what their normal is. So it could be their baseline mental status, how they normally respond to things. The other night we had a call where I asked the patient a series of questions to check her neurostatus. Things like, do you know what day it is? Do you know who the president is? And she wasn't able to tell me some of those things. And her daughter said, well, that's normal for her. She normally can't say those things or tell you those things. Objective versus subjective. Subjective things are things that you cannot see or can't be observed. So those are symptoms. So if somebody tells you they're nauseated, that's a symptom. If someone is vomiting, that's a sign. So objectively, I can see that they are, puking. So things that you can smell, see, touch, those are objective information. They're signs, where subjective are just things the patient tells you. So signs versus symptoms. wear for all patient encounters. And, we routinely also call that BSI, but body substance isolation. So standard precautions, most of the time, is just a pair of gloves. But now, post-COVID, it's a mask. And we'll also take some transmission-based precautions based off of whatever we're trying to avoid. So if we know the specific pathogen, it may require a certain type of respiratory protection or a certain type of protection of your eyes. The number one way to prevent, these pathogens, things making us sick, is washing our hands. And you never want to, have patient contact without washing your hands prior and after. And also, you don't want to go after you touch a patient and go smoke a cigarette or eat food. Your PPE, your personal protective equipment, is there designed to protect you, to keep you from coming in contact with hazards, not necessarily the patient, but it's your personal protective equipment. And then MRSA, I think I mentioned that last class. That's a bacteria that's resistant to antibiotics. And like the nurse told us, as far as we're concerned, everybody has MRSA. Infection spreads with the pathogen, and from an infected individual to someone that tries to invade a new host, but you have to be susceptible. You have to have a route of the transmission. Intact skin that's not intact, or if you're not protecting your respiratory system. We have a duty to protect ourselves and the people in our care from the spread of infection, and not to mention your family members back home also. And those standard precautions we're going to use on every patient, on every interaction. Some more of the standard precaution things are washing your hands before and after providing care, properly disposing of their PPE, and we'll treat any bodily fluid as infected, and properly clean and disinfect. I mentioned that before. Frequent hand washing is the most effective way to prevent the spread of pathogens. So if you want to stay healthy while doing the job, make sure you wash your hands. Here's how we wash our hands. So we're going to turn on the water and get our hands wet, apply soap, and then you're going to rub your hands together with some friction. At least 20 seconds. I like to sing happy birthday. I sing happy birthday to Oprah Winfrey and Brad Pitt because it makes me laugh. I think it's funny. And it gives me the time I need, for the soap to work. Then you always want to keep your hands kind of in a downward fashion. You don't want to lift your hands up so it runs down your elbows. So then you'll rinse. You grab a paper towel, dry your hands off, and use that paper towel to turn the water off. And then you can use that paper towel to open the door to the bathroom you're in, or just throw it away. And then here's a long list of when you're going to wash your hands. It's basically anytime you do anything. At the beginning of the shift, the end of the shift, and every time before and after you touch a patient. Donning your gloves or putting your gloves on, it's pretty simple, which I'll bring some gloves into class so we can practice. You're just going to slide your hand in. Oh, if your hand's really sweaty, sometimes it's hard to get it into those gloves, but just kind of work on it. To remove the gloves or doffing, you can pinch the palm, kind of wad up some of that glove, and slide your hand out of that glove, and then with the next hand, you use your two fingers to slide under the cuff of the glove you kept on. You never want to make a slingshot out of it, shoot it to a trash can, because little drops of blood or body fluid can get aerosolized in the air. So it says you must wear gloves anytime they're providing care to a patient under contact precautions or with open wounds. I'd say most of the time, 99% of the time, you're going to be wearing gloves no matter what.
if you have a full set of PPE, because you could go into a room that has full precautions, there's a certain way to take everything off. And you can read this whole list, but you kind of open the gown, you're going to pull it down through your arms through the sleeves, and turn everything inside out away from you. And before you enter the patient's room, if they do have some type of contact precautions, there should be a sign clearly on the door of the need for the contact precautions and what exactly you have to wear. And don't forget about airborne precautions. Of course, in the COVID kind of world we live in now, most of the time you're going to be wearing like a little surgical mask, but it may require an N95 respirator. And the 95 part just means that it filters out 95% of airborne pathogens. And I believe the surgical mask filters about 80% of airborne pathogens, somewhere in that neighborhood, 80, 85. When you have droplet precautions, you're going to want to wear a face mask, because these are people who are coughing like tuberculosis patients, or be sneezing, or maybe they're providing suction in the room, and those droplets can get aerosolized, and you don't want it to get in your eyeballs. So we'll wear a face mask to protect our eyes. These are just some other different contact precautions. Patients with MRSA, pink eye, C. diff, you don't want to touch them. So you'll also wear it like a gown. So you'll have a gown, gloves, mask, eye protection. All that's just to avoid contact, any direct contact with the patient. And OSHA requires a bloodborne pathogen standard. You'll probably have to do annual training for it in wherever you work. And OSHA requires a written exposure control plan. They require that the employer provides the PPE. They have to provide free hepatitis B vaccines. You can usually decline those, but they're made available for you. And it is extremely important that you report any injuries while on the job. So especially if you believe you've been exposed to some type of a bloodborne pathogen. So follow the exposure policy for that. I'm going to pause this real quick to make sure my microphone hasn't stopped. Okay, I think it's still working just fine. So make sure you become familiar with your infectious control policies, and make sure you use the PPE that's provided. Protect yourself. It's just maybe what if you had to take vital signs on a patient that has influenza, or you're performing an EKG on a patient with MRSA? What type of PPE do you think that you're going to be required to wear? Some of these, some more terminology things. Diaphoresis or diaphoretic, that's skin that's profusely sweating. They'll usually be pale and diaphoretic, kind of cool, clammy skin. Cyanosis, that just means that usually you'll see the lips and the nail beds will be kind of a bluish color. That's due to lack of oxygen. The body temperature reflects the balance between the heat created by the body. We're burning sugar all the time. Heat loss in the environment. If you have a quick change in temperature, it can cause seizures. So the fever doesn't have to necessarily be very high for a febrile seizure. It just has to change quickly. And another thing to think of with those body temperatures, if the patient's hot to touch, they're febrile, they're also hypermetabolic, and they'll be burning through their sugars. There's different areas where we check a temperature, whether it's oral, tympanic, like on the ear, axillary is in the armpit. So most of the time we're doing oral temps. You might see some rectal temps for younger kids. They have specific probes for those. If you have to check someone's temperature, you're going to introduce yourself. You make sure they haven't like eaten or smoked or drank food or drank drinks or food in the last 10 to 20 minutes, because when they smoke, it causes vasoconstriction. So you're going to get an inaccurate temperature in the mouth. So basically, you're just going to do the same thing you always do. You identify yourself, tell them why you're there, confirm the patient's identity, wash your hands, put your gloves on, do the procedure, get rid of the little probe cover, put the thermometer up, take your gloves off, and then wash your hands again. And it will all just depend on what facility you're working at, whether you even do these. Most of the ones I would say at the Big Mac, they're not doing these. They're just going room to room, obtaining the 12 lead. But these PowerPoints are available on your desire to learn, so you can go back through, slower if you want to read these. Some significant variations in skin condition, the pale skin, the flushing of the skin. These could be symptoms of a heart attack, being pale and diaphoretic. It could be due to a heart problem. So if you have any cyanosis or mottled skin, you need to let the doctor know, or a provider. Some more terms: pulse. That's usually felt down at the wrist for radial pulse. That's every time the heart pumps and the left ventricle pumps, it will, of course, have the blood pulsating through the arteries. Palpation means to feel or touch. So if someone might have a broken rib, I would say I'm going to palpate their ribs. Auscultation means to listen to, and that's using the stethoscope. And I mentioned radial pulse already. We also can check a carotid pulse. So if the patient is alert, talking to us, we usually check a radial pulse. If they're unconscious, we usually check the carotid pulse on the neck. Brachial pulse is most likely used for children, and that's between the elbow and the shoulder on the inside of the arm. Kind of push that area up against the bone. The heart, the base of the heart is where it attaches to the great vessels, and then it comes to like a cone shape that's kind of faced off to the left side of your chest. And the tip of that is called the apex. And if you take a stethoscope and put it right on the apex of the heart, you can listen to the lub dub and you can calculate the pulse rate. These are just a bunch of different locations where you can check pulses. Most of the time, it's going to be a radial for adults if they're conscious, or a carotid pulse. And for kids, for babies, we'll check brachials up there between the elbow and the shoulder on the inside of the arm. Some guidelines for pulse: the normal range is 60 to 100. Anything less than 60 we refer to as slow or Brady, and anything greater than 100 we refer to as fast or tachy. So if you hear someone say bradycardia, that means it's lower than 60. Your tachycardia is faster than 100. The coronary arteries are the only arteries in the body that perfuse while the heart's at rest. So that's why it's very important that the heart rate doesn't become too fast, because once you get above 150, it's really hard for the heart to perfuse itself. And one of the things that you'll find is when you're trying to, say, calculate someone's respirations, if they know you're counting their respirations, they will inadvertently change their breathing. Like all of a sudden they become aware of their breathing. So what I'll do is I'll check the pulse. Or I act like I'm checking a pulse, but I'm actually looking at their chest while I'm holding the wrist. So I'm feeling for the regular versus irregular and fast versus slow for the pulse, but I'm actually looking at their chest and counting the respirations at the same time. So I'll do the respirations and then I'll focus back again on the pulse rate and count the number of beats. Same thing as every other procedure. You're going to introduce yourself, identify the patient, wash your hands, do the procedure, wash your hands. I'm sorry, put on your PPE, do the procedure, remove the PPE, wash your hands, and leave. I mean, you can go back through and read all these. This is how to check an apical pulse, and that's where you're listening with a stethoscope to the tip of the heart, just like that picture. And she's counting the lub dubs. So each lub dub is 1. And so you'd have to lub dub 1, lub dub 2. So you have to count those. The sound of the lub dub is actually there's valves in the heart that are closing. And you'll learn all about that when we do A&P of the heart. Some more terms. Respiration. That's just the process of inhaling and exhaling air. A better term for that is actually ventilation, but we still use the word respiration. Truly, respiration happens at the cellular level, and that's where we exchange gas, CO2 for O2. But it's a holdover word. Like they used to call ventilators, they used to call them respirators a long time ago. So now they're called ventilators because that moves air in and out of the chest. Apnea is the word for not breathing, the absence of breathing. Your tachypnea, that's breathing too fast. Dyspnea means that they're having a difficult time breathing. Orthopnea, that's difficult breathing when they lay flat. And I already mentioned tachypnea. Cheyne-Stokes is a period of breathing fast and deep, and then it gets shallow, and then they stop breathing, and then they repeat the process. They start breathing again, but shallow to deep to shallow till they stop breathing. And you see that, I've seen that a lot with head injuries. So people with brain bleeds. Whenever you're listening to someone's breathing, it's really good to listen to the airflow in and out of the lungs. And but you can just notice, like, if they make sounds on the inhale, then that's an upper airway obstruction. And if they breathe in, no problem, but they make sounds on the exhale, like wheezing, that's a lower airway obstruction. Let's see. Measuring a pulse and respiratory rate. I've already talked about this. I'll act like I'm measuring a pulse, but I'm actually doing their respiratory rate. So this young man here, using the mouse, he is checking a pulse. He's really looking at her chest to see how many times a minute she's breathing. And then he'll start counting that pulse. Some more terms: blood pressure, that's the force that's exerted on the walls of the vessels, the arteries, when the heart's pumped by that left ventricle, or when the blood's pumped by the left ventricle. And we can measure that and kind of figure out whether or not they're perfusing their brain and their kidneys and vital organs. Hypertension just means the blood pressure is high. It's greater than, it says here 130/80. Most books will have 140/90, but because Hartman has it on here, just remember the 130/80. And then there's also hypotension, where the blood pressure is too low. So you can have hyper or hypo, sorry. You have a systolic blood pressure. That's the heart when it's working. So that's when it actively pumps. And you have a diastolic blood pressure, and that's when the heart relaxes. A sphygmomanometer, which is probably not, I didn't say that probably right, but you can YouTube video the correct pronunciation for a blood pressure cuff, because that's what everyone calls it, is a blood pressure cuff instead of a sphygmometer. Like sphygmoman, see what I mean? It's crazy. I already mentioned tachycardia and bradycardia. And we'll also practice doing a blood pressure when we're in class. Especially if you never obtained one on somebody before. It's definitely a skill you need to learn. There is a condition code is known as white coat hypertension. Those are people that are have a lot of anxiety or nervousness around, medical people, doctors, and their blood pressure will be normal. And then when you walk in the room to check it, it spikes up high because they're literally, it's just fight or flight. They're anxious. So what can we do about that? Well, we try to make sure we talk to the patient and keep them, get them at ease before we do the procedure. Pediatric vital signs, the rates, like the heart rates, are usually a lot faster than adults, and their blood pressure, of course, is a lot lower, and but their body temps will be about the same. Pulse oximeter, that's that SpO2, and that measures the amount of oxygen in the blood, which is called oxygen saturation. Hypoxia is the lack of oxygen, and that's what leads to things like cyanosis, where your lips are blue and you're not getting enough air, oxygen for the tissues of the body. There are some conditions that can make it hard to obtain an SpO2 reading. That could be wearing dark nail polish, a patient with perfusion, like say they've been outside and their hands are really cold, or maybe they're on some medication that is a vasopressor, so they don't have good circulation to their hands. The normal range for patients is 95 to 100% on that SpO2. Same thing, you can go through and read the step-by-step on how to do it. But basically, you're going to walk in, introduce yourself, explain what you're doing, identify the patient, wash your hands, put on your gloves, apply the pulse ox, remove the pulse ox, doff your gloves, wash your hands, and then document your readings and get out of there. For pain, we use an acronym called OPQRST. That's onset, when did it start, what provokes your pain? Can you tell me what quality it is? What's it feel like? Does it radiate? What the severity is, so the pain scale on 1 to 10. We can also use those Wong Baker faces. You'll see a chart on the wall from a smiley face to a frowny face. Oh, there it is right there, bam. So we use this mostly on kids or even adults that are, developmentally challenged, or they just can't, they have a hard time expressing themselves. These are some symptoms that are associated with pain. So I don't like how they say symptoms there, because if someone's sweating, it's not a symptom, it's a sign, right? If they're vomiting, it's a sign, it's not a symptom. That nausea is a symptom. So anyway, I don't like how they have they do have signs and symptoms. Okay. Tightening of the jaw. So if you see someone who's in pain, they'll squeeze their eyes shut, tighten, the jaw, can make fists, grind their teeth, increased heart rate, groaning, crying, repetitive movement, cussing. I've seen that a lot with pain. So how do we reduce pain? Well, first off, document it and take it serious. Never ignore or dismiss it. I told you all about the medical study where, Black folks don't get pain medication like white folks do. Why is that? So make sure you factor in your own bias for these things. For checking someone's level of consciousness, I usually use an acronym called AVPO, AVPO. So are they alert, which means their eyes are open and they're responding to me? Are they alert to verbal, which means they're unconscious until I give loud verbal stimuli to them? Are they unresponsive, meaning I give loud verbal stimuli and I'll do like a sternal rub and check for painful response? And so that's a kind of a full kind of neuro assessment. And it can be difficult getting history, past medical history from dementia patient, Alzheimer's patient, and hopefully they're with a family member or a caregiver that can provide some history on the patient. Because if not, you might think that they have, altered mental status, but it's just normal for them. The supine position is where a body would be laying flat on its back on the ground. Fowlers means they're sitting up about a 45 to 60 degree angle. Semi-Fowlers is 30 to 45 degrees. So there's supine position on the top left, and then there's a semi-Fowlers on the bottom right. So it's already the chapter review. So what's the difference between an objective and subjective patient information? Give 3 examples. Objective would be things I can see: vomiting, bleeding, crying. Subjective would be dizzy, weakness, and nausea. Just list and describe 2 government agencies that are concerned with infectious control and safety, and that's OSHA and the CDC. 4 types of PPE. You have your face shields, mask, gowns, and gloves. 3 types of transmission-based precautions, and give examples of the disease. So if you have someone who's got MRSA, you're going to have contact precautions. So you'll have a gown, gloves, probably a mask, and a face shield. I'll let you do the other 2. What should be done with disposable equipment after you use it? Well, we're going to expose it in the proper container and then wash our hands. What's the first step when taking someone's vital signs? I don't know. I guess you could say the first step is introduce yourself. Say, hey, my name's Murley. I'm here to check your vital signs. Can I get your name? And then I check their name on their bracelet. List 3 factors that might cause a patient's temperature reading to be inaccurate. If they recently eat or smoke or drink, those would definitely mess up their temperature readings in the last 10 minutes. Where and how are apical, radial, and brachial pulses measured? Apical is at the apex of the heart, so listen with a stethoscope. Radial is on the wrist against the radial bone, and brachial is between the elbow and the shoulder and inside of the arm. How does the EKG choose the right size blood pressure cuff for the patient? They actually have markings on there. So their arm should land, the diameter of the arm should land within those 2 marks. And if it's too big, it will give a abnormally low blood pressure, and the cuff's too small to give an abnormally high blood pressure. Some causes of hypotension could be dehydration or blood loss, or heart failure. And hypertension, it could be due to head bleeds. It could be due to too much salt retention, so that keeps fluid in, or an overload of fluid. Let's see, 3 factors that can interfere with pulse ox: dark nail polish, poor perfusion to the hands, and darker pigmented, also skin, that can interfere with pulse ox. 5 signs and symptoms that indicate the patient is in pain. So remember those with the clenched teeth, the rocking, the cussing. You can do the rest of them. When assessing the patient's level of consciousness, why is it important to know the baseline for the patient? Well, that way we can monitor whether the patient's trending up or trending down. List situations where the vital signs should be reported to the nurse immediately. Anytime you have abnormal vital signs, you need to report it immediately. So if it's too high or too low, you need to report those. And that's it for chapter 2, man. Hope everything's going good. And I'll catch up with you later.